Thank you. Thank you very much, Jessica and Umar and everybody else at ECHO team. I'm humbled and really honored to be given this chance to share this experience that I have gained over the years of treating nephrotic syndrome in children. I'll be sharing a lot of our research and a lot of the data that we have seen here. So to begin with, I have no conflict of interest, and how I will do is I'll talk about the problems with the diagnosis of nephrotic syndrome, and then the classification, the epidemiology a little bit, first episode of the treatment of first episode, then the relapses that occur after viral infections or otherwise, the treatment of frequently relapsing and steroid-dependent nephrotic syndrome, a little bit about steroid-resistant, and the difficult to treat nephrotic syndrome. So we have a lot of ground to cover. I will pace myself up. If you feel that I'm going too fast or you want to discuss something, you can stop me in between and we can, clarify things and then go on. So this very beautiful picture of a kidney, human kidney that you can see, we are talking about just a small portion of this glomerulus. And in this glomerulus, you can see that there is a filtration barrier. This filtration barrier, this is the space, urinary space, has fenestrated endothelium, the basement membrane, and the podocytes. And this picture on the side has shown a diseased podocyte, which is fused. So because of this, all this proteinuria occurs and we get the nephrotic syndrome. So how we define it is that basically it's either a dysregulation of our immune system or it's response to certain allergens or viruses, or it's a structural defect. Either one of them would lead to heavy proteinuria, hypoalbuminemia, which is less than 2.5 milligrams per deciliter, and a progressively increasing edema over a period of days. And then hypercholesterolemia is usually the tiebreaker because all these symptoms may be present in nephritic syndrome as well. It's only the proteinuria, which is the nephrotic range, that again is a very difficult to entity to quantify. We'll go on to that in a little bit. But the key pillars in the diagnosis of nephrotic syndrome, to me, is still progressively increasing edema. If you do not have edema, even if you diagnose nephrotic syndrome on the basis of lab parameters, the treatment of nephrotic syndrome, you don't have any objective thing to treat, and labs can always be deceiving. So if I don't see edema, I don't start treatment of nephrotic syndrome. But all these other features of nephritic syndrome, like hypertension, microscopic hematuria, acute renal dysfunction on presentation, or thrombotic tendency, these all, again, are key features of nephritic syndrome, where there is all active immune-mediated reaction going on in the kidneys. But these can be seen in almost 1/3 of patients with nephrotic syndrome too. And you'll see in further slides that these may help us predict some things in nephrotic syndrome. So again, the key feature is enough proteinuria to cause hypoalbuminemia and progressively increasing edema. And when in doubt, you check the cholesterol, which has to be high in nephrotic syndrome. These are the KDIGO guidelines recently published in 21 that has defined the nephrotic range proteinuria. And as you can see, the first line that I've underlined in red says that nephrotic syndrome for nephrotic range proteinuria, if you, they have given different cutoffs for different tests. For 24-hour urine, it has to be more than a gram protein in a day. But if you're checking it through urinary protein creatinine ratio, it has to be more than the ratio has to be more than 2 grams per gram, which translates into around 2 grams of proteinuria in a day. And if you're checking through a urinary dipstick, as you can see here, it's 3 plus or more, which is more than 300 to 1000 milligrams per deciliter. So in 100 ml, it's about a gram. So if you're putting out almost a liter urine or a 500 ml of urine, then in a day, then it's around 5 grams of protein, right? So different tests would have different cutoffs for nephrotic range proteinuria. And it becomes very, very difficult for clinicians like myself when we are sitting in a clinic. For the first time, a child comes to us and we don't know, we cannot get a timed 24-hour urine at that time. It needs at least 3 days. One day we order it, the second day they collect it and then submit it. And then even if we process it on the same day, it will at least need 3-4 days for us to get the results just to diagnose nephrotic syndrome. If we check the urine protein creatinine ratio at one point, I mean, at the extremes of proteinuria, it's not very sensitive. We have a lot of literature on that. And the cutoff again is 2. The ratio is 2. But for the urine dip, they have put up a very high cutoff. So if a child comes to you who has generalized NSRCA, who has low albumin, and the urine dip is still 2 plus, so it would not qualify as a nephrotic range proteinuria. And it does not take into account the size of the child. For a very small child, it could still be a very high degree of proteinuria, but still for these, if you follow these KDIGO guidelines exactly, accurately by the book, like many of us would like to do, you would face a lot of difficulty in diagnosing nephrotic syndrome. This is just one study that we have recently just submitted to the journal for publication. We analyzed 42 children. We collected the urine samples at the time of presentation, if they presented to us either with first episode or with relapse. And we asked them to collect 24-hour protein, and we did a protein creatinine ratio at the same time on them and a dipstick, and also collected the clinical parameters. We were sure that they have nephrotic syndrome, okay? And surprisingly, only the creatinine ratio was in 93% of children was sensitive enough to pick up nephrotic range proteinuria. When we collected the 24 hours, more than half of these collections were inadequate, because to check the adequacy of collection, you have to check the, you correlate it with the quantity of creatinine in their urine. And that creatinine depends on their body weight. The body weight is always overestimated in nephrotic because of the edema. So the muscle mass does not actually represent the actual weight and the muscle mass of that child. So the creatinine is always less, and it's usually under collection. Although the parents have been taught very well and they are very compliant, they have collected it. We have even collected urines with a Foley's catheter for 24 hours. And still, we did not get adequate collections if we use that creatinine criteria. So 24-hour urine in nephrotic children is not a very good test to document nephrotic range proteinuria. And same thing happened with urine dip. In 50% of the cases, they did not have +3 proteinuria or more. So we compared it with the UPCR as the gold standard, and the sensitivities were also 80 and 7, around 80%. So you will miss a lot of children if you go by these KDIGO guidelines very strictly. It has to be seen in the context of that patient, that if a child comes to you with generalized anasarca, progressively increasing edema, and then has proteinuria, which has resulted in hypoalbuminemia, enough to give them to bring their serum albumins down to less than 2.5, then we can safely diagnose them with nephrotic syndrome and start our treatment. Okay. Now, a little bit on the incidence. The incidence of nephrotic syndrome varies worldwide. And that is clearly seen in most places, that there is a different incidence in different ethnic backgrounds. Us Asians are most prone to it, and you can see this long bars with Asians wherever they are living, either they're living in North America or Europe. They have a higher incidence of nephrotic syndrome, and even in Pakistan, it is very high. A little bit behind us are the Arabs. They have also a high incidence of nephrotic syndrome, followed by the Afro-Americans or Blacks and Africans. And then it's very less in the Caucasians. So to keep this perspective, when you're applying a research which is done mainly on Caucasian population on Asian children, you have to see this, you have to keep reminding yourself that their incidence is not as high and their genetic makeup is different from ours. So the variety of nephrotic that we see is a lot different than is usually seen elsewhere in the world. So how we classify nephrotic syndrome is basically, there are multiple ways to do it. One is based on age, where you can say either it's a congenital, infantile, childhood, or adolescent, based on at what age they first time presented with nephrotic syndrome. In the first 3 months, it's usually a congenital one with structural abnormality of proteins in the filtration barrier. The infantile ones are one of the most difficult ones to treat, with a very high incidence of steroid resistance, but they can respond to steroids in few cases. The childhood variety is the garden variety, most commonly seen, and luckily a lot of them are steroid sensitive. The adolescent ones are usually midway between the childhood and the adult variety. The adults have more of membranous nephropathy, while the children have the MCD as more, which is very steroid sensitive as compared to adults. So the adolescents are somewhere in between in all kind of spectrums in most of the series that were reported across the world. You can also classify them based on the histopathologic lesions, the minimal change, FSGS, the IgM, MSPGN, and IgA nephropathy. And you can classify them based on the steroid response. That is the most used classification because it has implications in the treatment of this disease. So those who would respond to steroids, a full dose of steroids, which is either 60 milligram per meter square or 2 milligrams per kilogram per day, and their proteinuria remits, their edema resolves, they are called the steroid sensitive ones. Those who would respond to steroids but would continue to relapse as soon as you would taper the dose of steroids consecutively for 2 times or within 2 weeks of stopping the steroid. If they do that, then we label them as steroid-dependent nephrotic syndrome. But if they do not respond in 4 weeks at all, like the proteinuria did not reduce and the edema actually got worse, then they are steroid resistant. There is no need to continue that steroid therapy in those children if they have not responded in 4 weeks. However, there is a small proportion of children whom we see that they have kind of partial response in a way that their proteinuria reduce and their edema improves a little bit or significantly in 4 weeks. Those are the ones that can be given that trial for 2 extra weeks, and they should respond in that time. Within 6 weeks, if even their proteinuria has resolved, even if their edema has resolved and they continue to have proteinuria, then they should be labeled as steroid resistant and should be considered for alternate treatment. The frequent relapsers are the ones who are not steroid dependent and steroid sensitive. These are the ones who would, continue to relapse at least twice in 6 months or 4 times in a year. And all those that are left are the infrequent relapsers. Okay, so this is the main classification of nephrotic syndrome based on the treatment response to steroids. And this is the one that we use most often in our clinical practice. And this is what we are going to discuss also one by one as to how we approach them.
So Ali, just to add a point, I think if you could go back to the previous slide, I think we had the same discussion last time as well, that the steroid resistant one, the time is different in adult population and pediatrics. Would you like to share that? Adults is slightly longer, right?
3 to 4 months. And this has been studied well over decades now, that children are very sensitive to steroids. And if they do not respond in 4 weeks, the chances of them to respond in with the prolonged duration, with higher doses of steroids are way less, and the toxicity of steroid would have long-term, lifelong complications for them. So this is a consensus which most people in the world now agree with, that a child less than 12 years of age, if has not responded to steroids in 4 weeks or 6 weeks, should be labeled as steroid resistant and considered for alternate therapy.
Thank you.
Sure. So this is our study. We published this in 2009. Till then, we had seen around 3,000 nephrotic children, of whom we had biopsied around 538 of them. And you can see their categories. We do not biopsy the sensitive ones, but the dependent we used to biopsy at that time were around half of them were steroid dependent, and there were 168 steroid resistant ones. And you can see that MCD was the most common lesion that we saw. It is interesting to note here that there were quite almost equal number of FSGS who were both steroid sensitive too. So there is a prevalent concept, especially among adult nephrologists, that the FSGS is the really bad variety of nephrotic syndrome that has steroid resistance and goes into failure and does not respond to therapy and all those bad prognostic signs. Once you are diagnosed with FSGS, you get scared. But we have seen some good varieties of FSGS that got completely treated and went into remission just with steroids or with cyclophosphamide, a brief course. And the other important thing to note here is the low frequency of IgA that we saw in our cohort. In Pakistan and our Asia, we do not see IgA that often as compared to what they see in Far East, like in Japan. What they did was they did a school screening test with urine dip on everyone, and anyone with any abnormality would get biopsied. And in those biopsies, they got a lot of children with IgA nephropathy. So it was basically the indication of biopsy that was different. We do not do biopsies on any healthy looking child with just an abnormal hemoglobin in the urine or protein in the urine, non-nephrotic range protein in the urine. Only if it is giving some other clinical manifestations, we would consider for biopsy. So the low frequency of IgA in our cohort was probably because of the different indications of biopsy, but still we do not see IgA that often as other parts of the world. So now let's get to the treatment of first episode of nephrotic syndrome. A child who comes to you, you've diagnosed them with nephrotic syndrome, and which steroid would you prefer? Prednisolone has always remained as a reference drug. There have been trials with deflazacort, but they've been very small cohorts, 9, 10 patients. There have been 4 studies that Cochrane reviewed, but all of them were very small studies. They had shown that it has at least same efficacy or a little better results as compared to prednisolone. But deflazacort is not readily available, at least not in Pakistan. And if available, it is at least 100 times more costly as compared to prednisolone. So unless we see very different results with any other steroid, we are kind of stuck with prednisolone. They have tried dexamethasone and hydrocortisone also, but those studies were very poorly designed and still did not show any significant beneficial effect. So prednisolone remains that drug. Okay, so prednisolone to be given to that child, how will you calculate your dose? Would you take that weight 2 mg per kg or the meter square based regimen? 60 milligram per meter square per day. So if you want to do that mathematics with meter square, be my guest, divide weight and height and take a square root. And all us doctors who went into medical college, the primary reason was that we were not good at maths. So whenever I tell my students to calculate a meter square dose, then the first thing that reflexly goes, their hand goes in their pockets to take out their phone and take out that calculator. However, if you want to do a 2 mg per kg per day, it's simple. You just double the dose, the weight, and you'll get the dose. So calculation errors with milligram per meter square, personally, I feel that it is more, we doctors are more prone to make errors there. And Bagga Saab did this study that he calculated dosages on same patients based on meter square and the other group on by milligram per kilogram, and he found out that there is no difference. And actually, with the meter square based regimen, there was a higher tendency because the cumulative dose of steroids given through that calculation was a little higher. So the frequency of hypertension was also seen a little higher in other studies. So I go by weight base. So now prednisolone, that has to be calculated 2 milligrams per kilogram per day. Now, would you give one single daily dose or would you divide your dosages? And if you divide it, how many times would you divide it? 2 times, 3 times? I've even seen people dividing it by 4 times. It's just that you have to give 8 or 10 tablets, and then you want to divide it so that it becomes easy or less threatening for the parents to give, that it's only 2 tablets 4 times a day rather than 8, all 8 tablets in one go. It is all dependent on how you counsel them, and it has been studied also. So it is, again, Dr. Baga's first study in 97, the first randomized trial he told me was on this, and he did this by checking, by making two groups. One was given just a single daily dose and the other was given in 3 divided doses. And the effect was same. While this other study had seen this, that they said that if you divide the dosages, the ACTH suppression of these patients is more, because the ACTH secretion is in pulsatile fashion. And if you keep giving those smaller dosages the whole day, then the frequency of side effects is higher, or should be higher, in divided doses. So for last many years now, we've been given only 1 daily dose after meals in the morning, and we do not prescribe regularly any GI protection things like the omeprazole or the mucane, aluminum magnesium syrup, or the H2 blockers. The reason behind that is that has been endorsed by the KDIGO guidelines too, that you do not need, there is not enough evidence to say that you would definitely need a proton pump inhibitor or an acid reduction therapy with steroids. The chances of having a major complication of a GI bleed with steroids is less than 1%. So routinely, you do not give them. Only if they complain with gastritis-like symptoms, you can use any one of them. But you have to remember that the mucane, the aluminum magnesium syrup, which is one of the most commonly used, decreases the absorption of prednisone. And the dosages of H2 receptor blockers are usually, they are not very children friendly. The tablets, they are very high dosages. Those that are available in the syrup form, again, has to be carefully seen. The PPIs, omeprazole specifically, are easily available now, even in sachets, but not in syrup, and they are capsules. So smaller children finds it very difficult to take them. So we do not prescribe them regularly. We give single daily dose and 2 milligram per kilogram and per kilogram. Okay. So the edematous child with mild to moderate edema who comes to you and is seeking treatment, you start these steroids. And it is basically the edema that the parents are worried from, and that's what they get want the treatment for, and they want a quicker response. So it is very commonly observed that as physicians, we prescribe diuretics for mild to moderate edema. But the problem with that is that when you give diuretics, it is basically if the edema is because of that underfill, then the diuretics are not going to work that efficiently. And the furosemide specifically, it blocks the sodium pumps in your loop irreversibly for at least 6 days. Okay, so all that concentration ability of that kidney is gone. And when your steroids would take effect, and that is when you would need those loops to function at their best. So it's actually, it may cause any harm for treating mild to moderate edema with diuretics. All that is required is just fluid restriction and salt restriction in a way that it's just low salt when they have edema. Most of us, in our enthusiasm to treat, we tell them, koi namak nahi, no salt. No salt diet means that the whole house would now stop eating salt. They would stop putting salt in, and they'll have a bland diet at home, and the child would not eat, and that usually is the main complaint, that he does not eat. And when you go into detail of why he doesn't eat is because he doesn't like the food. And the reason why behind it is, if you have tried eating a no salt food, you would know that it is so difficult to eat. And there is really no added advantage of taking away salt from the diet. You can still have some salt that is needed in the food. It's just that added salt while you are edematous may increase your edema a little bit more than what it usually is. So I am very vocal about this in our clinics, that, I do not stop salt, just reduce it, that you do not give them added salt, only till they are edematous. The other thing is very common use of albumin for the treatment of edema. We use it, and all international guidelines endorse this, that it has to be used only for severe edema that is disabling. The child is unable to walk, or has some respiratory compromise because of the tense abdomen, the diaphragm is pulled up and has pleural effusions. And then, yes, you need diuretics, and if they don't work, you give it with albumin infusions. And in some cases of those underfill ones where it doesn't work, we may even tap them and take that fluid out. So for that, all aggressive treatment of edema is justified, but short of that, to treat mild to moderate edema, all that is needed is just fluid restriction. For male children that are more commonly affected by nephrotic syndrome, they get this scrotal edema, which is usually the main presenting complaint. A father brings the child very worried, and the scrotal skin is such that, with little edema, it becomes very thin and shiny, and it seems as if it's going to blast. And the father is mostly scared that now his progeny is in danger. So he would not listen to any nephrotic range proteinurias or the kidneys. All he wants is the treatment of that scrotal edema. That should not look that bad. And actually, the whole treatment because of that look of that scrotum, parents and the child themselves are so anxious that they don't touch it even, and it happens so often that they bring the child to us with a big scrotal swelling, and as soon as I see it, I go and I just pull that scrotum up. And when I touch it, both the parents and the child scream with fear, with anticipated fear. Oh my God, he has touched it. And then in a little bit time, they see that nothing happened. And then I squeeze it a little bit, and the edema reduces. And I show it to them. See, this is what is needed. This bag will continue to fill with water till it's hanging. You have to lift them up, make him wear a tight underwear, and pull this scrotum up and put it back to the abdomen. And that is the best cure of that scrotal edema, immediate. Okay, so that is one important thing that I've learned with practice, that it works. Okay.
Ali, can I share something?
Yes, please.
So thank you for sharing your perspective and real life experience. I know that you presented your own data today. You taught us the martial arts of using the prednisone dosage, like how to use it in an easy way.
Not yet, it's still to come.
It'll continue. Yeah. But I think the reason I'm sorry to interrupt. The reason I want everybody else to also learn is, like, I'm learning new things, like the salt theory, which you presented. I think I'm sure it's valuable, because I always use the expression with my patients that salt is the magnet for the water. But then I see them getting a lot of acute renal failure because we over diurese them or underfill their volume because of the so much restriction. So I think there was a very good point for me to learn that treat when the edema is extremely bad, then your strategy is super aggressive. But as this starts to get better, back off a little bit. I think that makes a lot of sense. And of course, when patients get a chest pain, so cardiovascular conditions get a lot of attention. I'm sure your compliance from the patient is higher because of the scrotal edema. So this is the chest pain equivalent for them to take the medicine. So thank you for sharing this perspective.
Sure. Okay, so I see a lot of parents who come to us, they are very, very anxious because not many physicians are comfortable in treating this nephrotic syndrome. And this we have learned by default that, when we cannot treat, we scare them. We tell them different stories. Parents would come to us telling different stories. The doctor told us that it is an infection of the kidney and it's going into failure and he will die or he will require dialysis, and you rush him to a kidney clinic like SIUT. And when they come to us, before coming to us, they see all those patients who are waiting for dialysis with all the lines, with children of ESRD who are being carried on a stretcher or a wheelchair or in a bad shape, all waiting in line, tired and very frustrated. And these parents, before reaching us, would think that this is where they are landing up. And my God, they can't even breathe when they get to us. So it is very, very important for all the physicians who are even referring these nephrotic children, at least tell them that this is a treatable condition. It can be treated, and it is very rare for them to go into renal failure. And if they do, even then it is, in a lot of cases, even in the steroid resistant ones, as you'll see, that they are treatable and they get better. So reduce their anxiety. They need to do something more. So tell them to bathe the child every day, keep them clean, make sure that they take their medications daily, regularly, and preferably at the same time of the day. And do not be worried with edema, and it is not an infection. More than 75% of these children would get better, and they may not carry this disease in their adulthood. I don't know what is wrong in our culture. With the rice, they have all kind of myths. And, if you have cough, you don't eat rice. If you have fever, you don't eat rice. If you have nephrotic syndrome, you don't eat rice. And if you eat biryani, that is a killer. That is like a poison, and that is usually the most liked food by children. It's very soft diet and they like it a lot. But we did a survey asking patients about the dietary restrictions that they follow. It's going to be presented in a nutrition conference just this week. We interviewed these parents asking them that which diet you don't give them since your child has nephrotic syndrome. And it had a lot of ethnic background too, that all these Pathans would not give them meat. Punjabis would restrict beef. The Hindustanis, the Mahajirs, they would not give them rice. All the different cultures would restrict their staple food from the diet of their children because they had nephrotic syndrome. So, and when we asked them, who told you to do that? We did not tell you. Did we? So, no, you did not, but we still did it. Why? Some other doctor told us, or it has to, and mostly they were the people who were living in joint families where the in-laws or the elder ones who were living together would restrict that diet from the food from their child's diet. So my only message is that It's just when they are edematous, a low salt diet, and fluid restriction. Fluid, how much? As much as they have urine output. It should be equal to the urine output. If they are passing good amount of urine, even that fluid restriction is not that mandatory. A child, recently I was walking in the corridor, a child saw me. She's a like 12, 13-year-old girl. And as soon as she saw me, she came running to me and hugged me. And I could not recall exactly when did I see her. And I asked her, how do you know me? She said that I had nephrotic syndrome and my parents had stopped water for me because I had edema. I was very, very thirsty. I complained to you and you went yourself and you brought me a whole glass of cold water. I still remember that. So still since then, I remember you. You gave me water when I was very thirsty. You know, when we tell our patients, our parents specifically for children to restrict something, I have seen mothers fasting themselves, not drinking water in front of their children for whole day because the doctor had restricted that water. And that doctor who had restricted had no idea what they were treating. It was just a reflex thing. Pani nahi dena hai. Don't give them water. And just that's it. They are all fasting then. So please evaluate your patients in context. Those who would require fluid restriction, give them some minimum amount. Those who are end stage, not passing any urine, can still drink a little bit water. They don't have to go that thirsty. If you treat them with that kind of quality of life, what is the use of treating them? I mean, allow some, some food and water and salt and things that, after taking that treatment, they would still get better. It is not going to change that much of their prognosis and the treatment response as we think it might. I have done that, been doing that for many years. It does not make that much difference. So if you can follow my lead, many patients would hug you in that corridor. But, my father-in-law, once we were sitting and discussing things, and he was of strong opinion that all the diseases in a human body would come through the gut. And it is always something that you eat will make you sick for all diseases. He was very sure of it. And I tried to convince him that these autoimmune diseases, we really don't exactly know how they come, but still, it has nothing to do with what you eat. But it has been seen. If you see all these 4 or 5 studies, being studied since 1977. Okay, and last 50 years, we haven't had much progress in this, but if you see the first study, he just restricted cow's milk. And remission occurred within few days to a month. There were other who restricted just gluten and wheat, or eggs, chicken, poultry, dairy, that they have seen remissions, sustained remissions, but there were only few patients, 4, 5, 10 patients, not more than that. And so this is just a food for thought, for it is now in our textbook, and it is one area that needs to be explored. Many food allergies or the microbiome of the gut may be the reason of this dysregulation of T and B cells, or some hyperactive response of the immune system, which may get better only by avoiding those allergens. Okay, so now we have so far established once daily dose of 2 mg per kg prednisolone, not sone. Sone is water soluble, but it is less absorbed. So prednisolone. How long would you give it for? This all started in 1956, and when Dr. R. Neal, he has his whole hospital named to him in UK, was an excellent physician. He treated only 4 children with nephrotic syndrome for 1 week of steroids, and their edema got better. And since then, since there is so much clear net benefit of steroids, we could not do any placebo-controlled trial on children to see if there is anything else other than steroids that would work. The first protocol for nephrotic syndrome was established in 1970s, 67 to 70s, when this whole world got together. There were 24 centers in 3 continents that got together. They admitted every child with nephrotic syndrome, biopsied everyone, and started treatment with 60 milligram per meter square per day, not to exceed more than 80 milligrams, in divided doses, and they gave them for 4 weeks. And after that, they reduced the dose to 40 milligram per meter square, which is around 1.5 mg per kg. And that they gave on 3 consecutive days, like Monday, Tuesday, Wednesday, and rest of the week off for another 4 weeks. So total 2 months treatment for every child across 3 continents, 500 plus children. And I think this is one of the biggest study done on the subject for ever, such a huge scale. And what did they find? They saw that almost 90% of these children were steroid sensitive, and more than 3/4 of them had MCD on biopsy. So they said, since this finding of MCD is so prevalent in all these nephrotic children, so those who are steroid sensitive should not be biopsied. And that's what it carried on since 1970s. And we have not done biopsies on children who were steroid sensitive. But what they did not do was they did not address the relapses. All these children who were treated for 8 weeks, almost 80% of them came back with a relapse, and they did not know what to do. They treated again with 2 months and kept on treating them with that same regimen for multiple relapses, which brought all the steroid toxicity and the need and drive to study this more, that, how should we address the relapse same as a first episode or not? And they did not talk about the steroid dependent and the resistant variety. So this task was taken up by the Germans, the Association for Pediatric Nephrology. We still owe it to them. That group did most of these fine tuning of this protocol, and they did all these comparative trials, multiple trials. They were published in the 90s. And one of them was on this every other day dosing as compared to 3 consecutive day dosing, like Monday, Tuesday, Wednesday versus 1 every other day. And they found that the EOD dosing is much better. Then this APN by far is, I think, still the only one that has done head-to-head trial of 8 weeks compared to the 12 weeks regimen. And they found that 12 weeks therapy for the first episode of nephrotic syndrome is much better as compared to 8 weeks in terms of relapses in future. And that is why the recent German guidelines published, I think, in 2020, still treats nephrotic syndrome for 12 weeks, the first episode. So this was in 90s. Okay, so now they had addressed all these trials were being done, and now we were treating for 2 months, and later on tapering with EOD dosing, and still the relapses were being treated with the same same protocol as the first episode. So this first meta-analysis by Elizabeth Hudson and her group in 2000, what they did was they compared studies that had given steroids for 2 months and compared them with all those other studies that had given treatment for 3 months or more. And they found that all those studies, all those children who had received steroids for more than 3 months did much better in terms of relapses as compared to the ones who were treated for 3 months. So based on this meta-analysis, the Cochrane and the other, before the Cochrane, the same group, since they had seen this benefit on more than 3 months, so what they did was they again divided the studies that had given steroids for 3 months and compared it with others who had given for 6 months or more. And again, the ones with a prolonged duration did way much better as compared to the 3 months one. And this brought this Cochrane analysis saying that the longer duration of steroids is much better in terms of preventing relapses as compared to the 3 months one. A lower dose after the first 3 months, and you taper it slowly over next 3 months to complete a duration of 6 to 7 months. Because giving steroids for every additional month over 2 months would reduce the risk of relapse by 11% every month. And this benefit is seen only up to 7 months and not beyond that. And the frequency of adverse effects is not higher in this group that is treated for a prolonged duration. So this 2005 was the year when I had started being a pediatric nephrologist, and I had seen this study. And if you had heard me then, I was one of those fierce advocate of prolonged duration of steroids, because everyone would stop treatment at 2 months. Most of them would stop at 3 months. And I would be just yelling everywhere that 6 months or more. Otherwise, they'll continue to relapse. For every relapse that I would see, I would be angry because they just don't listen. They don't understand. 6 months or more. And this recommendation continued in 2007, 2010, and further till Netherlands, Teninga. Netherlands and Belgium, they did a 5-year duration study, minimum follow-up of 18 months, equally matched, well-matched group, 12 weeks versus 24 weeks. Double-blind, randomized control trial, multiple centers, 2 countries, and studied all the frequent relapses, incidences of relapses, steroid dependence. No difference. No difference in relapses in neither group. So there was no benefit seen in prolonging therapy. But still, we had all this established for more than 30 years. This was just one study. Then came Bagasa, multi-center, 5 centers, at least 1 year follow-up, very well-matched group, 12 weeks versus 24 weeks. Again, double-blind, randomized control trial, very strong study, no difference. So this was 2013. That was about the time when we were starting our nephrology fellowship in our department. Pediatric nephrology fellows we were doing the journal clubs, and we were looking at these articles. The Yokishiwa, the Japanese trial, they did this mischief that they did 2 groups and 8 weeks versus 24 weeks, not 12 weeks. Okay. And again, same protocol, no difference. Yoshikawa. So this is 2014. Now, 3 big trials from different parts of the world, India, Japan, and Europe, all advocating that there is no added advantage if you treat them with a prolonged duration. And this is when we thought that now we will change our protocol to, till we saw this Cochrane analysis again, same Elizabeth Hudson. They said that, yes, before we had told everyone that you should treat for a longer duration, but now we have very strong studies to say that no, it has no additional benefit, but we would still wait for Pregnos to come. Pregnos was one of the biggest trial that was ever sponsored by NHS on any kidney disease. And it was going on, and they wanted to wait for Pregnos to make definite recommendation till it came. But it came in 2019. It took so long. They could not enroll patients because their centers, there were 86 centers, and the target was to achieve at least 300 children. They still managed to get 237. Minimum 2 years of follow-up till 2014. And again, a double-blind randomized trial that had compared 8 weeks of ISKDC protocol versus the 16 weeks. And what did it show? And the other thing they did in Pregnos was that they also gave leverage to the ethnic background. So post hoc analysis was done on different ethnic backgrounds too. And they also checked other things like the quality of life. They also checked the steroid side effects and the cost of treatment. So all these studies, all these things, they saw there was no statistically significant difference between 8 weeks and 16 weeks. 87 versus 139 children relapse, but it was not statistically significant. But there was something there, you know. You see that it's not like exact same like others had seen. There is some difference, but it's not statistically significant. And interestingly, they found that if you treat them with an extended course of 4 months, it's more cost effective for the queen, you know, for the government to pay for the treatment. Because if you give them a lower dose for a prolonged duration, they don't have to come for follow-up that often. They don't go for testing that often, and they don't relapse in that time while they are taking that treatment. So the overall cost was less when they treated for prolonged. So now this Cochrane did the same meta-analysis again. And this time it had Pregnos, India, Netherlands, and Japan with it. And they compared the ones that had treated for 3 months or more or less. And there was, in most cases, you see there was very little difference in terms of relapse. So now they recommended that that you should treat only for 3 months, or there's no benefit in prolonging the duration. And this KDIGO last year came up with all these recommendations that if you're diagnosed with nephrotic syndrome, the first option is the glucocorticoids. And if you're responding, then you treat them for 8 to 12 weeks. And if you're steroid resistant, again, 4 to 6 weeks, you do the biopsy. And if you are not, you are a frequent relapser or steroid dependent, you go to alternate therapies. And if you're an adolescent, you should be treated like an adult, but there is preference if you can get a genetic testing. So now our group, we wanted to make some kind of consensus, because in all over Karachi and Pakistan, wherever these children were being treated, they were treated very differently. Everyone would use their own protocols. and there was no common consensus. So we made up this document, and then we circulated among all our members whom we knew, where pediatric nephrology services were there, and then we discussed and came up with this consensus guidelines, in which when we diagnose nephrotic syndrome, we give them steroids for first 2 weeks. And once they have achieved remission, we continue the full daily dose for 4 weeks, 2 more weeks, and then you decrease it for at 1.5 mg per kg every other day for 8 weeks more. So the first episode is treated for 12 weeks. If you do not respond in 4 weeks' time, and if you have partial remission, then you give 2 more weeks. If you achieve remission, you go back to this side of the algorithm. But if there is in 4 weeks no response, or at 6 weeks there is partial response, we label them as steroid resistant and do a biopsy and treat them with alternate medications. Now, what we've seen is that all these nephrotic children, whenever they develop an upper respiratory tract infection, a viral infection that is characterized by cough, fever, runny nose, or they may even have an acute gastroenteritis or conjunctivitis, otitis media, any of the viral infection would trigger a nephrotic syndrome relapse. And this idea came first to Mattu Saab. He's a Saudi-based physician who had practiced in Saudi Arabia and in US. And he randomized children who had URI and gave them steroids for 5 days, daily prednisone for 5 days, and then stopped. And he said that he was able to reduce the relapse numbers to half. While they have this active viral infection, you give them steroid low dose for 5 days and you can prevent that relapse. This idea was carried forward by our very good friend Abia. And Abia, when I saw him, I told him that I had promised to myself that when I'll see you, I'll touch your feet. You are such a wonderful scientist. He did these trials, which to me are the strongest study design that is possible in these cases. He did crossover trials. Those patients who came to him with URI, he treated them with 1 week of steroids, and half of them were treated with placebo. And the next time over, when they would come with URI, those who were treated were now given placebo, and those who had not would receive the treatment. So, and if you were able to show these kind of results, 18% and 11 versus 25 relapses, it's wonderful. I mean, this is it. And you would be able to reduce the number of relapses overall in all patients with nephrotic syndrome, because almost 80–90% of them would come back with a relapse. And in those 90%, 80% are related to upper respiratory tract infection. And those KDIGO guidelines last year also recommended that. However, again, that PREDNOSE 2 trial was awaited, and we were not sure that how those results would advocate this giving low dose steroids. And PREDNOSE 2 finally came. Again, a huge study. They again had a lot of problems in enrolling children, because not many of these children were getting URIs, and their enrollment criteria, that enrollment went on for 7 years to complete this 270 patients. They took all those infrequent relapses, double-blind, placebo-controlled, randomized trial. Their cutoff was again a +3 on a urine depth that the parent would check at home. And they would give, this high-grade proteinuria within 2 weeks, and they would then wait for 3 days, like consecutive 3 days of heavy proteinuria, and then only they would give them steroids, low dose, for a week. And in those 216 relapses in treatment arm, there were 216 relapses in treatment arm in 91 children and 237. So they said there is no difference. But you see, my point is that this is not what ABIA had done. You have waited very long for these URIs now to give them that relapse. And now with that full-blown relapse, you are treating them with a very low dose of steroid. So definitely you're not going to see that effect as he has seen. So for me, again, it is a very big trial. Everyone, you read those editorials and they say that, you know, they have nailed it, and they even did a post hoc analysis on Asian children and they said there was no difference. But I think they had waited too long. You know, ABIA was giving them steroids when they would develop URI and have a little bit of proteinuria or no proteinuria. But if they have URI, he would give them for a week. Here, they were waiting for 3 consecutive days for a heavy proteinuria. More than 3 plus translates to, like we just calculated, it's like more than 5 grams of protein in a day. So these were the results, that they did not find any significant differences. Whether you give them low dose for a week or not, you don't have to. There was no difference in escalation of treatment, reduction, behavior scores, and quality of life that they check with something. So for us, the protocol for URI would remain same. We would still, if they would complain of URI, we would give them, if they are off steroids, we'd give them 0.5 milligram for a week per kilogram. And if they are already on steroids, we would just, it's on every other day, we make it daily, the same dose. And within a week, if that proteinuria does not go away, we treat them as relapse. Okay. Can it be prevented? Can these URI-induced relapses be prevented? So our group, we got hold of some flu vaccines, 100 of them. Somebody donated it to them and we did not know what to do with it. So what we did was that we gave to all our nephrotic children who were in remission or on very low dose of steroids. And we compared them with historic controls. We could not make a control group because it was ethically wrong not to give some children that vaccine that has been recommended. And what we saw was that those who were vaccinated, as compared to those from previous year, the number of URI episodes were so less. And the number of relapses, again, was almost half. So we think that, you know, flu vaccine should be given to every child with nephrotic syndrome. In last COVID years, we are not getting enough flu vaccines because all the vaccine making companies are busy with COVID vaccine and they're not making enough vaccines, so they're not coming to us. But those who could get hold of it, we strongly recommend them to take flu vaccines. Flu vaccines not only prevent URI from the influenza, but from all other viruses. And it is also, it reduces the number of relapses from all cause URI. You're just vaccinating against flu, but they reduce relapses from all cause URI. One of our colleagues from Multan, he gave them Montelukast and for a year. And in 2 groups, one group got it for a year, 5 milligrams of Montelukast. And he also saw significant decrease in number of relapses. I was talking to another colleague of mine. He said, I habitually start them on Montelukast in every winter season, but I don't see any significant effect, but he has not actually studied them in comparison. So we're not sure. Okay, so risk factors, can you really tell which child is going to get into frequent relapses and steroid dependence at the onset? You know, if you collect these patients in the beginning, and then what we did was we gave them urine dipsticks for home and asked them to keep a diary that we don't do, but for this study we did. And out of all these 57 children, we wanted to figure out that over a follow-up period of a year, who are those patients who had early relapse time, frequent relapses, and would require more treatment. So it turned out that those children who were younger than 4 years or who did not have hematuria at presentation, or those who did not achieve remission within that first 8 days, first 1 week, were the ones who would get more relapses and would have that the number of relapses would be more. So this again tells us that you can predict from the very beginning those who are early responders and who are older children, they may fare better. Younger children are usually the ones that get a difficult variety. Now we come to the relapse. Okay. There are the queries that we have in our mind now, that is this relapse, should it be treated with the same dose and duration as the first episode? Should it be less, and for how long? The major concern again is the steroid toxicity, and should they be treated with a lower dose or shorter duration or both? And what is the definition of remission? Different people have used different definitions. There's one, mostly they use 3 consecutive days. So a parent has to check urine dipstick on the child. So every time the child says that he wants to pee, the parent will run with him or her to the washroom, collect that urine sample, take out that urine dip, and record that finding in a diary. I cannot imagine even doing that, you know, for consecutively for 14 days, you do that on that child. And if the child passes that urine in the washroom or while he's playing, he could not hold, mother could not get to the washroom in time, and there will be a whole war at home because the mother missed it. And if you want to label that remission on 5 consecutive days, it would be even more difficult, because there will be days when they'll have no protein, then again +1 or +2, and then again 1 +1 +1. So the median time to respond to steroids is 7 to 11 days, and that is well studied throughout. So if you give those full days steroids till 14 days, 2 weeks, you are actually giving just 1 or 2 extra doses of steroids daily, right? And by not recommending this daily dips, you would change the whole quality of life of that family. So this is what we do. We do not recommend them to check these daily dipsticks. But I know that all the literature, everywhere, remission is defined as consecutive, no protein for 3 days, at least. And many pediatricians I know, they would just admit the child to record that remission. So they would keep that child in the hospital so they can get the urine daily to dip it and make sure that that protein has gone. And after, even when it's gone, they will reduce the dose either at 7, 8 days, 11 days, or day 14. So what we do is on day 14, we check 1 urine dip at our clinic ourselves. And if it's negative, we reduce the dose. So, but that is not very widely accepted amongst our own fellow colleagues. Now, this is the history of treatment of relapse. Till the ISKD days, till the early 2000s, we were treating relapse as first episode. Then this society, they recommended a lower than a tapering dose over a month every time. And then the total duration was 15 weeks. I calculated from here, assuming that they would achieve remission in 14 days. And these two recent ones, they have recommended treating for 6 weeks, and this Canadian sick kit protocol is for 7 weeks. There are studies now, again, our friends from India, Bagasa, Aditi, what they did was they said that maybe we don't need that much steroid. The cumulative dose is what is toxic. So by giving them less steroids, they gave just 4 weeks of alternate day versus 2 weeks of alternate day after achieving remission. By doing that, they reduced the cumulative dose from near 1800 to 1200 milligrams. And there was no change in the number of relapses or relapse rate per year. Okay, so a very significant, again, a breakthrough study that will change the whole guidelines and recommendations in near future. Similarly, this study from Israel, they have published their pilot protocol, 3 different regimens for relapses. One is same as 2 mg per kg, the other one at 1.5 and 1. Only 10 patients in each arm, but again, no difference was seen. Even there was only 1 patient in 1 mg per kg group that required a higher dose that did not achieve remission. But again, it was a very small study, small group, just a pilot, and further studies like this RESTON trial is ongoing. They've also published their protocol. It's from Netherlands again, and they will be enrolling around 150 children with reduced dosages. So we are awaiting these results, and I'm sure these will change the protocol, the guideline protocol for the treatment of relapses. For now, KDIGO still recommends that you start with a full daily dose, 2 mg per kg, and when they achieve remission, you reduce it to 1.5 mg per kg on alternate days for more than 4 weeks. The 6 weeks protocol for relapse. And this is what we do also. At relapse, first we achieve remission, and we give it for 2 weeks. We don't check for 3 consecutive days. Okay, so now we have come to FRNS, and we still have SDNS, SRNS, and difficult to treat NS. Should I pace up? I'll pace it now. I'll be talking a little faster now. Okay, so for FRNS, the main queries again is that what we used to do back in 2005 when we were treating with prolonged duration of steroids, we were giving them very low dose. Even I had seen someone taking half a tablet every other day for many, many months, and they were not relapsing. So still, I would say that if they do not have steroid toxicity, it is one of a good treatment for frequent relapsers. But again, there is no objective way to see those that, those with a lower dose, when would they relapse? And it would require a very difficult study to undertake to study that serious effect, especially when you are comparing them with someone with a lower duration. So steroid sparing agents are always indicated whenever you develop toxicity of steroids. And the most commonly used treatment in this group is either MMF or levamisole. And our good friend Aditi has published this head-to-head trial between MMF and levamisole. They again randomized 150 odd patients and gave a very high dose of MMF and a recommended dose of levamisole. And for an intention to treat analysis, they did not find much difference. Either MMF was not superior in sustaining remission, in frequent relapses, in treatment failures, or steroid toxicity. In a small group of their patients, they had also did flow cytometry and checked all the lymphocytes, CD4, CD8, and all those, and they were also not different in either group. So what the take home from this study was that MMF and levamisole are almost same. But for us, it is different. MMF is very costly as compared to levamisole. Levamisole is very cheap. But both of them, they need frequent monitoring, and MMF levels are not available. So with those high dosages, if you still don't respond, what they recommend is to increase the dose according to the levels, MPA levels, and those are not available, at least in Pakistan, and not even at SIUT. So we're not sure how to treat those who do not respond to MMF. And especially given the cost, we think that, levamisole is much better, easily manageable. Other thing in this study, in Aditi's study, was that they had also included SDNS patients, which I think may have muddied the water a little bit in analyzing this, because SDNS usually do not respond very well in our own experience with levamisole or MMF. So that, I think, is one limitation of that study. But for FRNS, what we do is we use levamisole 2 to 2.5 mg per kg every other day, and we give steroids initially, then we taper it over months till we have achieved sustained remission for at least 6 to 9 months. And after a year, we stop all the steroids, continue levamisole for another year, and then stop everything. There are rare side effects with the liver toxicity. So we check the LFTs every 3 months. And there are few case reports of ANCA-associated vasculitis with levamisole and some leukopenias. It's basically an anti-helminthic drug that is an immune modulator, helps in FRNS. We have collected, we are yet to analyze our data on levamisole. There were quite a few. You see, I have this intrinsic bias with levamisole. I call it a Kida maar dawai, and I don't take it as an immune suppressant. So every time I see a failure of levamisole, it registers in my mind as levamisole is a bekar dawai. But my colleagues would disagree with me, and they think that levamisole is a good drug. We'll see when we'll analyze our results. For SDNS and those who have not responded to levamisole, what we do, we have published this also, that we, over 2 years, when we used to biopsy all the SDNS children, we don't do that now. Most of them were MCD, and the median time frame of 17 months had lapsed between establishing the diagnosis of NS and starting the cyclophosphamide therapy. Leukopenia was noted only in 6 patients. So we found sustained remission. We got sustained remission in 13 months. Median duration was 13 months. For more than a year, those who were relapsing, every time you would reduce the steroid by taking cyclophosphamide for 2 to 3 months, they reduced, the number of relapses reduced to 13 months, more relapse in 13 months. So this is how we do a cumulative dose. We calculate by multiplying the weight into 168, divided by 2 to 3, so that we finish it in 7 to 12 weeks. We start with steroids initially with 1.5 for 2 weeks, taper it slowly till last 0.25 is left, and we follow them every 2 weeks for next 3 months. Stop it if it reduces to less than 4,000, but we resume it again to complete the cumulative dose as soon as the TLC is up again. And when we complete the course, we stop all the medications, and we have found very good results. Those who still fail with cyclophosphamide, we treat them, then we do a biopsy and we start them with calcineurin inhibitors. And in this, our experience has been that we studied these 75 children in only 2 years who specifically were those who had received cyclophosphamide for SDNS and came back with a relapse. So we biopsied, and in those biopsies, the number of MCDs were a little less. There were a few FSGS2, IgMs, and at the last follow-up, 50%, almost half of them were in complete remission with CNIs. If you compare, add up the 35 with partial remission also, then gives a very significant response rate with cyclosporin. The renal functions also did not deteriorate significantly with the CNIs. Now the SRNS, IPNA has done a very good job in collecting all the experts from all over the world. People, I see names here from India, from Europe. Moin Salim is also UK, Germans, Netherlands. This is Midwest, Australia, China, Korea. So all big shots from all over the world in pediatric nephrology got together and came up with these guidelines. This practice of giving high-dose steroids at 4 weeks to establish steroid resistance is not recommended. Do not do that. If you can, if possible, you check systemic etiologies and other genetic testing if available, and start cyclosporin 3 to 5 milligrams per kilogram per day, not to exceed 215 a day, divide in 2 equal doses. You start ACE or R, preferably ramipril and not enalapril, because they are not metabolized by the kidney, the ramiprils and the ARBs, which otherwise, if you get dehydrated, would get accumulated in the kidney and cause more toxicity. Start with 1 milligram per kilogram on every other day steroids, and do not give steroids for more than 6 months. Remission is usually achieved within 6 weeks to 12 weeks. And then we taper off the steroids. But rarely, if they do not respond in 6 months, they're usually not going to respond. And we add ACE inhibitors, right? And then we, once they are in remission, you have tapered off the steroids, then we start decreasing the cyclosporin once every 2 to 3 months, little bit by little bit, till you achieve a lowest effective dose. And when they have remained in sustained remission for 1 to 2 years, then you can stop it. And a problem with stopping, in a Japanese study had reported 95% relapse rate, but we have not seen it that often. We haven't actually analyzed our data in that way. But yes, we don't see that often relapses with CNI after stopping CNI. Those whose creatinine would go up from CNI and there's evidence of toxicity, then they may be switched to MMF and stop the CNIs. And if they still relapse after stopping SIA, then we have to restart them at a little higher dose than what was effective in the past, and then bringing down to a lowest effective dose. Partial response are the ones who are edema-free, whose albumins are more than 2.5 to 3, and the levels of cyclosporin are adequate, 80 to 120. Those who do not achieve that remission after 6 months on cyclosporin, we switch them to tacrolimus, and we give them 0.1 to 0.2 milligram to get to a level of 6 to 8 maximum. And if they even achieve partial remission, then we continue that. And if that does not work, then rituximab is the only choice. IPNA guidelines say that all these other choices may work, but we have poor evidence for that. And if you do not have a genetic defect, then your chances of having recurrence in post-transplant are higher. If you have that genetic defect, that means you have that structural abnormality, and then chances are less. So a positive genetic mutation in an SRNS is a good news for parents. What we did here was we collected all the patients who had presented to us with nephrotic syndrome, and 100 odd patients, we collected their urine and stored them at -70 degrees. And once we had established them that out of these 135 patients were steroid resistant, and then we checked them for beta-2 microglobulin and compared their all other clinical parameters. And we found that those patients at presentation who had microscopic hematuria, hypertension, a very heavy proteinuria, and a beta-2 microglobulin level of more than 3 times normal were more likely to be steroid resistant. So, and this was a significant p-value. Sensitivity of beta-2 microglobulin in urine at the time of presentation is close to 80%. And we could not find any other risk factors, especially the presence of FSGS lesion on the biopsy as on our multivariate regression analysis. And this thyroid study that we did was we checked all of them on the premise that with this proteinuria, they may lose their thyroid binding globulins and become, they may have hypothyroidism. But luckily there were, at the time of presentation, there were almost 1/4 of them that had a higher TSH than normal. But most of them had subclinical ones, the T3, T4 were normal. And at 3 months, most of these patients, only one of them had overt hypothyroidism requiring treatment, but rest of them either had normal TFTs or just 4 of them had subclinical hypothyroidism. And what we have seen with CNI is in over 6 years, mostly FSGS in our SRNS population, and CNI toxicity was seen in almost 1/3 of them. Complete remission with cyclosporin was achieved in 1/3 and 1/4 with partial. So around 60% response rate, 15% required dialysis, and mortality was 17%. 13-14% loss to follow. One child received transplant with NS who had recurrence and lost his graft in 6 years. Now the last one, difficult to treat NS. And this one is, I think, would require a whole day again to talk about, but I have just summarized it in one slide, that it's usually those who have steroid resistance or those who develop it later on, those who are steroid sensitive, but later on with the relapses go on to become steroid resistant are the ones who become very difficult to treat, would not respond to any treatment. So what our usual algorithm goes is with steroid resistance is that we start with cyclosporin, achieve target levels, see for 6 months. If they do not respond, then we switch it back to tacrolimus, achieve adequate levels, and give them 6 months more. If no response, then we put them on a triple regimen with a low dose TAC, MMF high dose, and a low dose delta in a hope that they would achieve partial remission, at least become edema free. Some of them, very few of them would respond to this triple regimen, and at least 8 or 10 of these children who did not respond to triple regime also were given rituximab in our unit. And I know of only 2 or 3 children who responded to Ritux, even with a less than 1% CD19 count. So Ritux, because we use it very late in the course, and also it is not a very established treatment for steroid resistant. For steroid dependent ones, yes, it is a better one. But since we are treating steroid dependent ones with other easily available, less expensive medications, we don't give them Ritux regularly. So we don't know the real benefit of rituximab in these patients. But for steroid resistant ones, the difficult ones, if they do not respond to the other therapies, they usually don't respond to Ritux as well. And the most difficult and frustrating aspect is to treat their edema when they go into renal failure. They go into really, they have tense ascites, cannot walk, and especially it's cosmetically so bad. Children cannot move, they stop going to school, other children make fun of them, they hide in their homes, they're depressed, and their renal functions are not as bad that we would start them on dialysis, but their edema, we have no other way to treat. Diuretics don't work on them, even with heavy doses. When we give them oral medications, they don't get absorbed because they have gut edema also. They frequently have very high frequency of passing stools, loose stools, not really diarrhea, but they really are in a miserable shape. We have tried almost everything that we can think of. In some cases, we intentionally give them high-dose cyclosporin that their GFR would drop further, and then they will reduce their edema. In very few cases, we have seen that response. Otherwise, there is one adolescent girl who comes to us once every 2 months or so. We put a pigtail in her belly and we drain out 2-3 liters a day for a week, 10 days. And we teach the father how to take out that water. And in a week time, when she's flat again, we take the catheter out because otherwise it gets infected. And then again, wait for 1-2 months more to accumulate, and then we put that catheter again. Some of them we had started dialysis with that edematous lens. It is difficult to have a fistula. Lines get infected very easily. Fistula, even if you make them, they are so prothrombotic that they get thrombosed so easily, and very, very difficult ones. It's a dreaded complication of NS is the ones with severe edema and renal failure. And quite a few of them we have lost to infections. They come with very severe infections, florid septic shock, and would not come back whatever we would do. So finally, in all these hour and 45 minutes, there are only 4 points that you can take home. One is, this is my belief, that this one nephrotic syndrome of children is not one disease. It is a manifestation of at least 3 different diseases. One is that of the B and T cell dysregulation that responds very well to steroids. And then once that dysregulation is better, the communication, you treat them with some immune suppressants and they get better and they don't relapse. There's another one that is triggered by some immune responses to some allergens, either it's the diet or some viral infections. And these are the ones who would probably, they would go into spontaneous remission or would fare the best with either dietary restrictions or some kind of restriction therapy would help in this. They are very few in number, but we have to be aware of this number. There are children who go into spontaneous remission, and there are children who respond to this. And then these are the other difficult steroid-resistant ones and the congenital ones who have the defects in the proteins of their filtration barrier. And in these patients, I don't think immune suppression is the answer. It's not their immune system that is at fault. And the reason why we see response of cyclosporin in them is not because it is suppressing their immune system, but it is the intrinsic response of cyclosporin that helps reduce proteinuria in those patients with structural defects. So what we exactly need is that the one that we tried, the beta-2 microglobulin study, we need some other biomarkers that can differentiate between these entities so that we can exactly choose the tailor-made treatment for our patients. Some of them who would need a prolonged duration, some would need a higher dose of steroids, others would not. Some of them would respond to this viral infection so well, and others would not. So all this universal consensus is still evolving, and I have given you a flavor of all the literature that is there on these treatments and what we are following up till now. That is also subject to change. So maybe the next time ECHO will give me this chance, this whole guidelines will change, and I will tell, oh, we were so naive to tell you that, we should be treating these for 2 months or 3 months, and it doesn't need 2 mg per kg. So this is all evolving, but it's fascinating, and so far we're trying our best. I dedicate my talk to my guru, our chief and our role model, our beacon, Professor Edematous. Thank you very much for your attention.
Thank you, Ali. This was outstanding. This is wonderful. Not only that you shared the data internationally and the guidelines, but shared your own data, your own experience, and a lot of wisdom. I think the storytelling is very powerful. Sharing your stories of the patient, that message is strong, and this will stick to most of us in this Zoom room today for long. So we will remember from your story and maybe change some of the practice pattern as well. So thank you. So I will invite, I don't know if Dr. Masood is still here, or any of our other team member from the panel to say something. And then there was like one question which we sure can take. Avas, are you here? If not, then anybody from the panel, Dr. Akram, you want to say something?
Ji, Assalamu alaikum. Dr. E, it's a very wonderful talk, and giving us some new aspects in the management of nephrotic syndrome in children. The one thing which is very interesting, according to you, that there is no role of restriction of salt, no role of any restriction of water. But what about the restriction of protein? You did not mention about that. Is there any role of protein restriction or not? Number one. And then number two, at which stage where we should biopsy, and without any, the patient and the children who presented with that of the nephrotic syndrome, either we will treat without biopsy, or at which stage we should do the biopsy.
Thank you, Dr. Mateen. Thank you for asking these questions. I had deliberately...
And one more question.
Gigi.
And what is the role of calcium supplement in the steroid-dependent nephrotic syndrome?
Okay, thank you for asking these questions, because these are really common ones.
Yeah, Ali, would you unshare your screen so we can see each other and then talk, it's easy if you unshare that.
Okay.
Sorry for interruption. Yep, this is much better.
Okay. So the first question is when to do biopsy.
Yes.
Biopsy in children with with nephrotic syndrome is now only limited to steroid-resistant nephrotic syndrome for sure. All those who do not respond in 4 to 6 weeks should get a biopsy. And you would still give them cyclosporin, all of them, regardless of their biopsy result. But the benefit of biopsy in those children is that the knowledge of histopathological spectrum of these diseases is still evolving. As you have seen that there is so less that we know. And unless we would study these histopathological patterns in more detail and these diseases, we would not be able to come up with any other newer modalities. Plus, when and if they would go into renal failure, we have seen our data in this too. Those children who develop AKI in nephrotic syndrome mostly are the ones who would have a prerenal or an ATN secondary to dehydration or volume depletion. They are the ones when you are not sure whether to hold off their cyclosporins in long run or not. If you have a biopsy at the baseline, seeing a healthy parenchyma, it is so much easier to treat them. Secondly, when you go for transplant in these children, if you have that histopathology in the beginning, and if they do not recur in future, you would add this to the knowledge that, you know, these children who had this kind of pattern, maybe we can see them 10 years down the line, but we have to continue collecting that data. And since this biopsy is a very easy procedure, safe procedure, we are yet to see any complication in thousands of biopsies that we have done. So Alhamdulillah, and that's why I think biopsy should be done in this, all steroid-resistant ones. There are 2 or 3 other indications. One is when we start CNIs in SDNS. So before starting that, we do a biopsy. Not for all SDNS, those are steroid sensitive, but only before starting CNI. Third is when we see a child with nephrotic after 12 years of age. First episode after 12 years, an adolescent NS should get a biopsy because their disease is completely different than the childhood one. So these are 3 main indications: SRNS, SDNS before CNI, and adolescent ones. Congenital ones, some people do, some don't. I don't see much of a difference there. And the fourth one is the atypical NS. Anyone with any atypical features. Your second question was about protein restriction in nephrotic syndrome. Again, a commonly practiced thing. Some people tell them not to eat the yellow of the egg. Some people tell them to take 6 eggs in a day and only the egg whites. Or some people would just say eat a lot of chicken. So some people advocate high protein diet, but what they fail to understand is that taking high protein diet is not going to replace the protein that they are losing in their urine. Because whatever protein you are going to eat is going to get digested and the protein synthesis will continue in your liver. So it is not going to make much of a difference. There have been studies done, especially in the MDRD trials. There was one group of nephrotics who were given a higher protein diet and the other one with normal and the other one with low. It did not make any difference. Okay, so does not make any difference. Just eat a regular diet. And the things with the salt and water is, again, has to be tailor-made specifically for that patient. It is not like one size fits to all. And the vitamin D, this fever of vitamin D among our doctors is, I don't know when it's going to get over. I have already treated quite a few patients with vitamin D toxicities with resistant kind of hypercalcemias, 11, 12, and it's all because of everyone just blindly giving vitamin D injections and oral drops in mega quantity. There is no defined role of vitamin D in any of the nephrotic patient. I don't see how it would work also. The low albumin would increase the, would decrease the ionized calcium, right? The total calcium, you have to correct it for the albumin. So the ionized calcium remains same, but it's just the other, total calcium is low. But usually very few of them become symptomatic. And if they do, we give them calcium and vitamin D, but mostly we don't see that often hypocalcemia in regular nephrotics. It's just those ones with very prolonged, very severe ones.
Okay. That's all from my side.
No, thank you. I think what I was thinking, if we compare the approach to lupus nephritis in adult population, so that's where you really want to do biopsy and maybe another biopsy before the second round of treatment for that accurate diagnosis to classify it and see what the chronic damage is. I think in the pediatric nephrotic syndrome, really the trials have been focused on how we can use the available treatments in the best possible way. So excellent discussion.
Omar,
can I invite Dr. Mubarak to say something? I mean, I know he's been with us throughout. I'm not sure if he is available to talk. He is your I see his name on most of your trials you publish. So this was my personal request to Dr. Mubarak.
He is the one who started all this.
So are you able to say a few words?
Okay, till Dr. Mubarak says anything. There are a few questions in the chat box.
Yep, I think that's
one about one is how to treat congenital nephrotic. I again deliberately did not go into it because it's rare, and luckily it's rare. It's a very bad disease to have. Before 3 months, a child born with oligohydramnios, swollen placenta, it's usually low birth weight, premature one, or even if at term, they're very swollen, very sick children, immune compromised, with a structural defect in their filtration barrier that you cannot treat with medications. So most of the times, all we do is we treat very severe anasarca. Otherwise, we tell the parents to get used to this edema. Because if you keep giving them diuretics, then after some time, they become diuretic resistant also. Role of albumin is not, albumin doesn't help either after some time. So we reserve these treatments for them for edema. We give them ACE inhibitors, we give them thyroid replacements, because at that age, if they would even, the replacement would not make them hyperthyroid, but if they are severely hypothyroid, then they will have all kind of other problems too. And they give them ACE inhibitors and do a genetic counseling to the parents that, the chances, the odds of having another sibling with same disease are much higher. So, think twice before planning another child. Another question from Dr. Shams is, did vaccine administration precipitate relapses? Not in our experience, no. It actually just helped everyone. All-cause URI and in relapses, specifically in nephrotic syndrome, did not precipitate relapse in even a single patient of all the 100 that we had studied.
One last question from Dr. Kumar about if parents don't want to do the biopsy, then what are the other protocol or guidelines? I think you covered this, but if you take the...
Sure. I mean, you see, we do biopsies under general anesthesia in operating theater with a nephrologist, a radiologist, anesthetist, and a person from histopathology with a dissecting microscope, who will tell us that, you know, one core is enough or not, take a second core only if it's needed. In that case scenario, our biopsies are very safe. And thank God we have not seen a single complication in all these 17, 18 years of my practice with a severe complication in any child with nephrotic syndrome. With AKI, we may have seen bleeding in 2-3, but not with nephrotic ones. So it's a safe procedure. It takes hardly 3 to 5 minutes for us to do a biopsy, and 10 to 15 minutes. It's an outpatient thing. They come out in the morning and leave by the afternoon. If this counseling doesn't work and they don't accept it, it's okay. Specifically for solitary kidneys or ones with any other structural defect of the kidney, we also prefer not to do a biopsy, and we treat them empirically with, if they have steroid resistant one, we treat them with cyclosporin or, you know, whatever other medication. So it will change their outcome only if you are treating, you are dealing with some kind of atypical disease, a rare disease.
Dr. Shamas has raised his hand, so maybe he wants to say something, he or she.
Thank you, Dr. Ali, for the great presentation. I was just curious about the salt restriction. I think maybe it does not matter clinically if somebody is going to switch off proteinuria after steroids intake in 2 to 3 weeks. But what about steroid resistance ones? If they are persistently nephrotic, if they keep eating salt, they probably won't respond to the ACE inhibitors and diuretic therapy. That probably would just worsen the nephrotic syndrome. What are your thoughts on that scenario?
You see, Dr. Shams, the nephrotic syndrome in children is very different from adults. Children, in most cases, respond to steroids within 2 weeks' time. Okay, and those who do not respond in 2 weeks would respond in 4 to 6 weeks or would respond to other alternate treatment. So 70 or 80% of them would respond to it within that first 4-6 weeks of their disease. For them to give these dietary restrictions, you see the salt restriction, you should listen to Dr. Magdi Yaqub. I think he would be here also in PSN. Dr. Magdi Yaqub gave an excellent lecture on this salt restriction. The last time I saw him, I think it was in PSN or somewhere, I think when he was visited SIUT. It's an overrated thing between us nephrologists and physicians that the salt intake of, in our Pakistani diet, the usual salt intake is not more than the recommended daily allowance. And with that regular intake of salt, it will not worsen the edema that significantly as it would decrease their appetite and would alter the whole family will be affected, because if the child, if there is only usually one kitchen, they cannot cook a different meal for a child. So if it has to be a low salt diet, then the whole family has to suffer. And if you show me that significant difference that regular salt intake will cause, in thousands of patients that I have treated, I have not seen any and yet to see. If you have seen any that you can show me, I will trust you and I will change my practices. Till then, I would continue to follow my own practices.
So maybe we can take this opportunity to move a motion to end the session, because I want to keep some of the questions and participation for next time. I think, Ali, we might be requesting you to have another follow-up session to discuss some of those theories and
some of queries as well.
So any last comments or something you want to say, Ali? I wish that if Dr. Mubarak is able to say something.
Yeah, it's very late for him. He's usually an early to bed and early to rise. So I'm sure he may have joined the session and dozed off. But on his behalf, it all started when I had joined this pediatric nephrology department. Within a year or two, he came to me and he said, do you know the wealth of data that we have? Why don't we start writing it? And I said, I can collect the data, but I do not know how to write it. And he said, don't worry, that I can do. You just collect the data for me. And that's how our team, we both teamed up, and we started looking into our files. We collected 15 years data in 2007 to 2008. And in that one data set, we wrote 7 papers in that 2 years' time. All these histopathological spectrums and adolescent NS and all these most cited papers came from that data set, and then it continued. So Dr. Mubarak is our guru in paper writing. I think he has more than 130 publications to his name.
We all need gurus like him. So thank you. Thank you, everyone.
Thank you.
I think until we meet next time, I think our next session is in April after the PSN. So I will be joining and probably meet most or some of you at PSN. So until then, Assalamu alaikum and Khuda Hafiz.
Khuda Hafiz.
Khuda Hafiz.
Thank you. Khuda Hafiz.